Okay, so in the essence of everyone's time, we'll go ahead and get started. Looks like we have just over 150 attendees. I'm Mark Ray. I'm the local sales consultant for Biodesix here in the Western Tennessee market. We appreciate your time joining us this evening. We think we've got a great expert panel that will share some great insights. If you will, go ahead and mute your lines, please, so that we allow the speakers to present their wisdom unimpeded. We will take Q&A at the end. Feel free to use your chat feature during their talks, and we'll compile a list of those questions and address those at the end. But we want to keep this to about 45 minutes and open it up to Q&A, so we'll go ahead and get started. First off, I introduce our expert panelists. They are a wide swath of specialties covering thoracic disease. First up is Dr. Susan Garwood. She did her IM training at Vanderbilt and her pulmonary critical care at MUSC. She is an advanced bronchoscopist with Centennial Thoracic Surgery Associates in Nashville and serves as the Thoracic Oncology Medical Director for HCA TriStar and as the National Physician Director for Pulmonary Service Line for HCA corporately. She's launched over 100 incidental nodule screening programs across the HCA system, and she was an early adopter of robotic navigational bronchoscopy, having led the country in volume. And we were just talking that she's over 1,000 procedures completed to date. So that's quite an accomplishment. Next up is Dr. Maurice Smith. He is a thoracic surgeon at Frederick Health Hospital. He's also the chair of the Department of Surgery there for Frederick Health. He leads their early pulmonary cancer detection program and has ordered over 100 Nodify tests himself. His medical training included stops at UNC Chapel Hill, Medical College of Georgia, and Johns Hopkins for his thoracic surgery fellowship. And then last up, we're joined by Dr. Samuel Riney. He's a medical oncologist with Methodist Healthcare here in Memphis, Tennessee. He is a product of Memphis and pursued his medical education through the UT system and chose to stay at home and fight the nasty disease that lung cancer is here in the black belt of lung cancer in Western Tennessee in the Deep South. He specializes in thoracic oncology and is the lung nodule program director for Methodist Cancer Institute. As the head of the early detection program for Methodist, he's an avid user of both Nodify and of IQLung, so he'll speak on that later on. But without further ado, I'll kick it off and let Dr. Garwood take it away.
I'm really excited to be here and grateful for all of you who took the time tonight. This space obviously is very near and dear to my heart. As Mark talked about some of my journey, obviously I am an advanced bronchoscopist, so my job is to identify these nodules, but also I carry a national hat where it's very important for me to help guide others. What I always say is I'm about 200 mistakes ahead of you, because we do have access to some of these technologies earlier on. So I like to share a little bit of that flavor as we go about how I use this personally and then how we direct some of the national conversation. So what are we talking about tonight? So next slide. The first thing obviously is a very personal discussion because as a pulmonologist, my job is to look at CT scans and help advise about who I think needs to have an intervention. Just because you have shiny new toys like robotics doesn't always mean that everybody needs a procedure, even though that is my life's work. So we use this example as a very good CT example of how, as physicians, our eye and our clinical experience may not always be perfect. So the CT to the left is almost a 3 centimeter solid nodule located in the upper lobe, patient completely asymptomatic. The one to the right is kind of a more irregular shape, a little bit flat, a little bit smooth on the edges, but only 9 millimeters. So the question to the group is just think internally, what would you do if you saw these two patients? So would you do a CT? Would you do a PET scan? Or would you proceed with surgery outright? Next slide. And I think a lot of us have predetermined notions about which one of these were going to be malignancy. And as this CT shows, in this specific instance, the one to the left at 8 weeks showed near complete resolution. So that large area was indeed not malignancy. The one to the right was followed over time and showed some initial enlargement and went on to resection and was indeed found to be a 1A. So what this shows us is it's not always in the eye of the beholder. And so the question is, what else could we do other than our own training and clinical experience, which is valuable, but is there anything else on the market that could help us make a better clinical triage decision? Next slide. So if we think about lung nodule risk assessment, and when I'm training folks, the most important thing is are you doing this exercise at all? So every time that you see a nodule, ideally, you are going through some type of risk calculation. We tend to err towards the side of Mayo. There's a VA, there's a Brock. All of those calculators depend on the cohort that you're dealing with. What's the pre-test or what's the prevalence of cancer? Mayo's kind of middle of the ground. So we're looking specifically at age, nodule size, speculation, the location of the nodule, and whether they've smoked yes or no in the past. Their cancer history is also important. So we put those things into a calculator. I always tell my physicians, I want you to document that number regardless. That is just proof that you are doing your due diligence, not just using a gut feeling about who needs to have a biopsy and who doesn't. But if we look at those with nodule size between 8 and 30 millimeters, and there are about 1.6 million incidental nodules, not even including our screening. If we look at those in that size range and we do the calculator, you'll see about 80% of the time, the patients fall in the indeterminate, I don't know what to do with risk. Those who are over 65% or the high risk population, they represent about 10% of our patients now. And it should be clear if you're in a high risk situation, if that patient's clinically appropriate to move to biopsy. About 10% of the time, the patients may clearly be low risk, and it's clear that serial surveillance is necessary. But the majority of the time, we are left in a gray zone. Next slide. So the question is, what can be done? Nodify Lung, we're going to talk about this kind of in two parts today. So I'm going to take the first part with CDT, and I'm going to punt to Dr. Smith, who's going to take you on the XL2 ride here. But we'll look at both. These platforms do work in tandem. The Nodify CDT test is a blood-based autoantibody assay that helps us identify likely malignant nodules. So this is the rule-in version of the test. 98% specificity, giving us an overall positive predictive value of 78%. Now, it's important to know that number. 78% is not 100%. But it does guide us to make a better clinical decision. It is reinforced by over 15 publications and presentations, and now is covered both Medicare, Medicaid, and commercial payers throughout our population. The Nodify CDT, the Nodify XL2 test is going to be covered by Dr. Smith, but this is also a blood-based test looking at proteomics. It is our rule-out version of the test, 97% sensitive, and 98% negative predictive value. So even better as far as a true, so this, if you're come back with the XL2 that's less than 5%, that negative predictive value is excellent. Again, backed up by many publications and presentations. Next slide. So if we look at more specifically how this works, all we're asking is for you to input those 5 main categories so that we have evidence of the Mayo calculated risk. So you'll see that pre-test information is where you enter those characteristics. And in this specific instance, it was determined to be 12%. So on the lower side, right? So CDT in this instance was performed, and it came back with a high level of autoantibodies, which changed that post-test risk over that 65% mark. So 66%. And in this instance, we would suggest that you need to move forward as you would with any other high-risk patient. So consider PET scan, consider doing biopsy, consider surgical resection if wedge may be appropriate. But this we would consider to be a call to action. They've made the report very easy to read, easily digestible with clear pre and post-test parameters. Next slide. So how did this test come about? To help identify candidates for intervention, this actually is measuring autoantibodies for tumor-associated antigens. Initially, this is not new to the field of thoracic oncology. This has been around for many years. The initial test had 6 autoantibodies. And after some thought and deliberation, they actually removed 2 of those and added 3 back. That helped optimize the specificity for the test. So this looks both for non-small cell and for small cell cancer. So it's assessing risk for both, which is very important when you're talking to your patients. A high level, 98% specificity has that 78% positive predictive value. A moderate level, however, is still very helpful. 93% specific, 59% positive predictive value. So those are the cutoff values we'll talk through. So now I want to talk through and share a couple cases so that you can understand how I utilize this in my practice before moving to Dr. Smith. Next slide. Oh, sorry, let's talk about the test performance. So actually when CDT came on the market, remember XL2 came out of the PANOPTIC trial. So when CDT was added to this algorithm, they looked at 317 samples from PANOPTIC. 263 of those were in the intended use group, and that was a 54% prevalence of cancer that was in that population. Of those, 229 were CDT negative, meaning there was no autoantibody expression, and 13% were CDT positive. And you can see this is where that positive predictive value came from. So 74% or 25 of those nodules were truly malignant. So very important to understand the validation behind this. And so that is how we got to this combination. And we'll talk about how they work in tandem as we go through the night. Next slide. So how do I use this? So this is an example of how a moderate antibody actually helps. So I think all criteria that we're going to talk about tonight, you have to think about this with the patient in mind. So this was a patient who's 63. She initially had a 5mm nodule detected on her screen in 2019. It did show growth up to 8mm in May of 2020, and you can see that highlighted to the right there. They were referred to a medical clinic, and not unlike a lot of my patients, the lady was on the heavier side in the South. She has sleep apnea, chronic pain, morbid obesity, some pulmonary hypertension, COPD, and needed a little oxygen. So overall, very healthy patient. Probably see some of these in Memphis as well. She also, like many of our patients, continued to smoke and had a long-standing smoking history and also a strong family history of lung cancer. She was not very excited to see me. Next slide. So we had a conversation at first, and she was very adamant that she did not think that anything could be done. She had been told, if you put me to sleep, then I will not survive, that there isn't anything to be done. So why do we need to talk about this at all? We conducted her pretest probability, and based on her initial imaging, that was only 7%. So she was very hesitant to proceed with anything, maybe not even surveillance. Next slide. So her post-Nodify came back, and it actually showed a moderate level of antibodies, and this piqued her interest. She was allowed to have a freer conversation about what are the possibilities of malignancy, and do you think that there are ways that you could get me through a procedure safely? And if you did find cancer, Dr. Garwood, is there anything that can be done? And so we had a very frank conversation about diagnostic possibilities using robotic bronchoscopy. Next slide. She wasn't super excited. Oh, sorry. Let's go. She wasn't super excited. Let's go back one more slide, please. She wasn't super excited about the small size of the nodule. We talked about navigational bronchoscopy. She was seen by surgery to see if she could be a candidate for resection. And the patient opted for an additional 3-month follow-up scan, but said, gosh, if it grows anymore, then I'll let you do something at that point. So at the 3-month follow-up scan, she had now evidence of 10mm. She had a PET scan, and the PET was negative, which if you think about the trajectory of this over a couple of years, it's not surprising that the PET avidity was low. Not felt to be a wedge candidate, so we proceeded with robotic navigational bronchoscopy. Next slide. And even with the small size, with our anesthetic protocol, she was able to get through that biopsy just fine. This proved to be a well-differentiated pulmonary adenocarcinoma. She had simultaneous EBUS sampling and went on to have SBRT, and she is still doing well to this day. So this is a couple of years out, but a great candidate to show how even moderate level results can allow you to have more informed conversation and do closer follow-up and really assess whether interventions could be more appropriate if you do see growth. So great case and great outcome for her. Now I'm going to shift a little bit to the next slide, the next case where this patient actually had no significant autoantibodies, but this is something I get very routinely, and then I'm going to pitch it over to Dr. Smith. So this is a 57-year-old guy. He showed up in our emergency room with chest pain and had a CT performed that showed this cavitary nodule. Now our ER physician told him, so sorry, you don't have a blood clot, but you have lung cancer. So that was the ER physician's quote. So that made my job very difficult. He also is a heavy smoker, 60-pack years, but no family history of lung cancer. Next slide. So he's referred into our nodule clinic. I do his risk calculator and it's 45%, and he is scared to death. He actually asked to be seen by the surgeon the same day. We arranged for a PET scan for him. Next slide. The PET scan showed avidity. So now I've got a 45% risk with the PET avid peripheral nodule, and I know our thoracic surgeon would be happy to take this out. PET uptake is 3.2. The next day, his blood test comes back. Next slide. And his autoantibodies are negative, and within a few days, we get the Nodify result that shows that his risk is now reduced to 5%. He already was extremely anxious, so before we could have further conversation, the patient was really insistent that this be taken out. Next slide. And you see at the time of diagnosis, this actually is a granuloma with chronic inflammation. So again, this just goes to the discussion. This could be added in, again, not that the patient had any harm done with the wedge resection, but this can really help us looking at those negative autoantibodies and the use of XL2 to figure out how we get a clear path forward. Next slide. And Dr. Smith is going to take us through. So we're really looking throughout the night is reclassifying risk, very low, low to moderate, and high. And Dr. Smith, take us through. So I'm excited to hear. I know you've got a similar case where these really helped informed how you move forward. So nice to work with you tonight, and we'll look forward to questions at the end. Dr. Smith.
So we'll go next slide. So first, let me say what an honor it is to be with Dr. Garwood and Dr. Riney. They are truly experts. And Dr. Garwood, those were fantastic cases. So as mentioned earlier, I'm a thoracic surgeon here in Frederick. I've done almost 110 cases just by myself, and that has been even larger number now. I think the reason why I'm such a high adopter is that I find it gives my patients peace of mind. As a medical community, I think we really underestimate the impact that watchful waiting has not only on our patients, but also the families themselves. It is pretty much all they think about for that 3 months in which they wait for that watchful waiting CT scan. I know the experts can relate, but you should really see the relief in patients' eyes when I'm able to tell them that we have a blood test that can further help risk stratify them, and that we can get that test back sometimes in 48 hours, but at the most 72 hours. Next slide. So remember, just as Dr. Garwood said, the XL2 part, which is an automatic reflex. So you get your CDT first. If the CDT is negative, the test will automatically reflex to this XL2. As she mentioned, it's a rule out test. What we're looking for in terms of rule out cancer, we want something with good sensitivity and a good negative predictive value. And this test meets all those criteria. This off to the right is one of my favorite things that I see. So if you take a look at that Mayo Clinic predictor, which Dr. Garwood was talking about, like look at location, speculation, smoking history, age, and nodule size, and you give them all a value. The two proteins, the ratio that XL2 looks at is actually equivalent in as much weight as nodule size. I can't speak for people on this presentation, but for me, that's a big deal. Next slide. So this is really just background information. Letting you know that the test started out looking at over 388 proteins, and then they narrowed them down to 2. Those 2 proteins they identified, one is LG3BP, also called MAC2. That is the proteins we identify in terms of lung cancer. Then there's also compare that to the protein or inflammation, C136A. Not that you need to remember this slide, but as Dr. Garwood alluded to, I think it's important you give the patients kind of the conversation of what they're to expect. So how I explain it to my patients is, look, the first test is going to look for specific antigens and antibodies, that's CDT. If that's negative, which I hope it is, the next test will help us risk stratify whether or not we can just look at you with the CT scan or whether or not we should actually do procedures. And to my patients, I describe this as this is the we don't have to poke you unless we need to test. And so it's very helpful. Next slide. So just as Dr. Garwood mentioned, this is evidence-based. So it comes out of the big PANOPTIC trial. As you can see, it's in chest in 2020. Big study, Dr. Tanner and Dr. Silvestri helped contribute to this. So what they looked at in terms of XL2, intended population use was 178. Out of that, 149 tests were benign. What I want you to notice is that 65 of those actually came back as likely benign. That's that like the very low risk, less than 5%. So that's 43.6% of the test came back as less than 5%, likely benign. Those tests with those people with confidence, you can just have them repeat a CT scan. But what's even more important is that out of that 149 that tested negative or benign, in 2 years, 132 were still negative. And the only other 17 actually were lost to follow-up. So basically out of all the ones that had follow-up, initially came back benign, they stayed benign at 2 years. Next slide. And this is how the results look. So what you're looking at is, in this particular case, when they looked at the pretest, so looked at size, location, speculation, smoking history, cancer history, this particular patient came back with a 40% chance of risk malignancy. But just like that actual test patient that Dr. Garwood showed, this patient came back as likely benign. Now, again, you'll get that likely benign when that risk of malignancy is less than 5% and you see that very low risk. Again, the reason why that's so important is that is the group of people that you can safely take to CT scan, surveillance, and should not be taken towards biopsy. Next slide. So how the results come back, you know, the 35% will come back as that likely benign. That's that very low risk, less than 5%, safely go to CT. 45% still incredibly useful, but they will have some evidence of reduced risk. And then this next is this indeterminate. Now I'm actually going to take some time to go through indeterminate, because I think indeterminate gets a bad rap. Basically what indeterminate is the test saying, look, I can't with confidence raise or lower the risk, so I'm going to actually defer to your clinical opinion. So to me, that's a good thing. We're going to dive into that a little more deeply. Next slide. So what you're looking at, and I can't speak for the other experts, but for me, I never really used this second page of data till about my 20th or 30th case and realized the importance of it. So what you'll get is you'll get that first graph, and then on the second page, you'll actually get this graph that'll have a bar across. So in patients that it gives you that 98% negative predictive value, that's that likely benign. As you go down further, when you get to that 95% reduced risk, that's getting more towards that 86% sensitivity. When you get down to 90, that's just a 55% sensitivity. So anything less than 90% negative predictive value, it'll give you an indeterminate value. To me, that's showing the value and the high standard that Nodify and Biodesix are holding themselves to. Next slide. And this is further looking at, and this will help you make sense. So when you look across that top line, when your Mayo Clinic pretest is 30%, if it reduces it to 3, that's kind of in that category of giving you that 98% negative predictive value, incredibly low risk. You can take that to the bank. When you get 30% and it decreases down to 10, still very good, 95% negative predictive value, and with confidence, you can take those patients just to surveillance. Now, when you start getting down towards 90, yeah, that's taking you from like 30 just down to 19. That gives you just that 55% sensitivity, and that's what kind of gives us pause. And anything less than that is indeterminate. Most people, and I think the expert will agree, if it's anything less than 95% negative predictive value, that's something that we kind of keep our eye on and do close surveillance. Next slide. Now, please, before you look anymore, please notice that star. So this is not a standardized approach. It's not endorsed by Biodesix. I don't need the big dogs coming after me, but just know that this is what I do. And I think you should take time to look at your data and develop your own system. But here in Frederick, if we get a Nodify CDT positive, just as Dr. Garwood said, we go towards performing a PET and sometimes performing a biopsy, depending on what that PET shows. If the XL2 is likely benign or less than 5%, we with confidence go to CT scan. If it reduces the risk, but only reduces it with a negative predictive value less than 95, we rely on our preclinical assessment. So that's early CT follow-up for us, usually like a 3-month CT. Indeterminate is the same for us. We go to early CT follow-up. But again, this is just a system that I've employed based on my data. Again, when you use the test with a lot of frequency, you'll be able to come up with your own. Next slide. So here's my first case. So this is a patient who was 50, ended up having a calcium CT score. And I'll say this, for us, our cardiologists are our biggest contributors to our lung nodule program. We actually went out and advertised to those cardiologists saying, look, you know, when you guys are ordering these CT calcium scores, which you do a lot of, if you guys get an incidental nodule, you're on the hook for it, let us take care of it. And that's really been our big one. So this is from that. So anyway, this patient had a calcium score with a 15 millimeter irregular nodule in the right lung base. Sent to their primary care, it had a chest CT, and this was really in short follow-up where this nodule that was 15 millimeters was now 21 millimeters, and then an opacity also in the left upper lobe. Now, patient was a lifelong non-smoker, but did have a first-degree relative without cancer, but had a wife who'd been diagnosed with stage 4 cancer. So obviously exposure was very high in our risk. Patient ended up having a PET scan. Next slide, and we'll look at that PET scan together. So this is a CT scan. When you look to the left of the screen, you'll see it kind of halfway down that nodule. And then when you look at the coronals, you'll see the same thing. In the right lung, you'll see it down there towards the bottom of the diaphragm. Next slide. Now, when I saw this PET scan, obviously I'm very concerned now, right? So you actually see high-low lymphadenopathy and stage 7 lymphadenopathy to that image to the left, and then to the right, you see the lung mass, which again is on this right lower lobe, so very concerning. Next slide. However, we end up getting the Nodify results, and this came back with this patient very likely benign. Now, let me say this. This was early in my practice, so the patient still did get biopsy and EBUS all at the same time. Next slide. And what happened is the CT biopsy came back with non-caseating granuloma. And then also on the EBUS, we got the same thing, necrotizing and non-necrotizing granuloma. For us, the reason why this is very important, and I know Dr. Garwood knows this, if you're still clinically suspicious after a negative EBUS, so if I didn't have this data, this patient would have been set up for a mediastinoscopy or possibly a wedge resection. So this case is one of those cases where, again, the patient did not have an unnecessary procedure, which is why I really believe in this product. Next slide. Now, obviously, I'm not going to talk about negative predictive value and not have a case for it because you guys knew this was coming. So CT scan. So we have a ground glass nodular opacity. It involved the posterior segment of the right upper lobe. You can see it down there to the patient's right on the left of the screen. The area measured 14 millimeters. Next slide. And this was a 70-year-old non-smoker, no history of cancer. She was sent to PET, and the PET was negative. The XL2 results reduced her from 33 to 21. However, and you'll see later, this is right at that 90% negative predictive value. So we did not proceed with anything more, but we did do short-term CT scans. On the next CT scan, patient went from 14 millimeters to 14 to 17 millimeters. And then we actually end up showing her the results. And because of us being able to show this patient the data, because she was very hesitant to have any procedure done, we were actually able to convince her to move forward with navigational bronchoscopy of the right upper lobe. Next slide. So this is that reduced, so 33 to 20%. Next slide. However, this is that bar I'm talking about. So you can see that she was just at 90%. It was less than that 95%. And again, realizing that was really just one tick away from indeterminate. That's why we continue to follow this patient closely. Next slide. So patient ended up having the nav bronch, end up coming back as adenocarcinoma. This was actually our first single anesthetic event case. So we did the nav bronch, and then later on moved to lobectomy. Those dates are wrong, it was the same date. But again, because of Nodify, patient was not willing to proceed with biopsy because the PET was negative. We had the data to have her think more about it and more open conversation, and able to offer her a biopsy with less comfort. And then again, we end up taking this out as early stage adenocarcinoma. Next slide. I'll pass the baton on to the anchor man, Dr. Riney. Thank you all.
All right. Thank you, Dr. Garwood and Dr. Smith. That's a great review of Nodify. I too use that testing in our lung nodule program, and we've found it to be very useful. But what I'm talking about today is something that's really excited to me, and that is the second part of Biodesix offering, which is a molecular testing for your patients that have been diagnosed with non-small cell lung cancer. So reason we do that is because in early stages, we can determine patients that might be available for adjuvant therapies or immune therapies. And then in advanced stages, of course, targeted therapies, immune therapies, clinical trial enrollments, lots of options there. So important information to know. And let's talk about why a little bit. Next slide, please. So molecular testing, I understand there might be some oncologists on, but everybody's probably vaguely familiar with the idea that there are certain mutations that should be tested for in lung cancer patients. But the reality is that tissue testing has kind of been the standard of care, and it can be very frustrating for several reasons. One of those reasons being it takes a long time, 3-4 weeks to get results back even in some cases. A lot of patients will have insufficient tissue that molecular testing can't be done on. I just saw a patient today that had a lobectomy, yet somehow insufficient quality of tissue to get tissue-based NGS. Because of that, a lot of patients are started on first-line therapy without those results, about 50%, according to the U.S. Oncology Network. And that's just from the past several years. Next slide, please. So why does it matter? What is important about having this information? Well, because patients that have actionable mutations, driver mutations, a lot of times won't have a good response to things like immunotherapies. And that's independent of PD-L1 expression. So even PD-L1 high might not do well if they have, for example, an EGFR mutation. There can also be an increased risk of immune-related adverse events if you don't sequence these treatments correctly. If you give someone that first cycle of platinum therapy with an immune checkpoint inhibitor and then find out later on they have an EGFR mutation, their risk of going on a TKI and having grade 3, grade 4 pneumonitis is actually very, very high. So much so that it's not recommended to do that. And then, of course, you have the potential to miss out on clinical trials. Some clinical trials are going to require patients that are treatment naive. Even if you've given them one cycle of therapy, that trial might not be an opportunity if they have an emerging marker. Next slide, please. So one quick case study. This is an example of a 71-year-old patient, non-smoker, had an abnormal chest x-ray and then went on to have a CT scan that revealed a fairly sizable mass, 3 centimeters, also had some hilar and paratracheal lymph nodes, and unfortunately was found to have bilateral lung disease, non-small cell lung cancer in this case. And at the time of diagnosis, she did have limited molecular profiling done. She had EGFR and ALK, which were negative, and PD-L1, which sounded really great because it was 95%. So that patient was then started on therapy. Next slide, please. With pembrolizumab as a single agent because of that PD-L1 high status. Seemed like this patient should respond well. Didn't have a known driver mutation. Well, the patient ended up having some dyspnea, developed hypoxia, went into the hospital, and you see the CT scans here on the right-hand side of the screen, where after just, I think 43 days, or I'm sorry, it's 25 days after the introduction of pembrolizumab. The tumor had increased in size. The patient was having new symptoms. Looked like didn't have any kind of response to the pembrolizumab at all, actually grew through it. So was immediately put on second-line therapy with platinum doublet, and then did have a response after that with CT scans done a few weeks later. So at the time of finding that progression, an entire next-generation sequencing was done. And that patient was actually found to have a MET exon 14 skipping mutation. So one of your rarer mutations in a few % of patients, but could have been detected early on and completely changed this patient's treatment outcome. They could have gone on a TKI medicine right from the get-go and probably had much better response. And might not have had progressive disease on pembrolizumab. Next slide, please. So that's where IQLung comes in. So IQLung is all about, if you could mute your microphone, please. So IQLung is all about getting you the information you need to guide your treatments and doing it quickly. So it's a combination of genomic and proteomic testing. And a lot of times you're going to get results back in around 72 hours for this testing, which is phenomenal. This is all blood-based testing. And again, blood-based NGS has been available before, but it's been pan cancer, and a lot of times takes, in my experience, 11, 14 days, sometimes more. So it can be slow, relatively, still faster than tissue. But IQLung, lung cancer specific, extremely fast, extremely useful in my clinic. Next slide, please. So what do you get with this test? Well, I actually have a lot of times the pulmonologist, the advanced bronchoscopist that work in Memphis with me, will draw this test at the time of biopsy. If you have rapid on-site pathology there, you have a cancer diagnosis, draw an IQLung, they'll send them to me a week later. I'm seeing them in clinic. I have my tissue histology. I have IQLung results. I have everything wrapped up in a nice little neat package where I know what's going on with that patient and know exactly what their treatment's going to look like, not only for the next few days, but even the next few months. And it really helps me be able to lead those patients in confidently with the information I need so that they can be started on treatment, or at least have a very clear treatment plan from visit one. Which has been great, as opposed to in the past where that first visit a lot of times is, oh, well, we've got to send off tissue and do NGS, and I need a little bit more time to know exactly what your full steps in treatment are going to look like. And that's frustrating to patients. So having this information right from the get-go has been very useful. What kind of information do I get from IQLung? Well, in early stage non-small cell lung cancers, you're going to get something called GeneStrat. Next slide, please. This is a targeted panel that's looking for mutations of interest in the adjuvant setting. So that's going to be EGFR, ALK, ROS1, RET, BRAF, and KRAS. Results come back actually pretty quickly. This is usually somewhere around 36 hours. And it's very sensitive and very specific. It uses this new droplet digital PCR technology, which is really a step forward when it comes to blood-based molecular profiling. Next slide, please. These are the mutations that you will actually get from the limited panel. So you'll see here, not only is it just your EGFR exon 19, but you're also getting exon 21, exon 20, some of your uncommon EGFR mutations, KRAS G12C, as well as G12D and G12V, some of the more emerging treatment options. So really a complete panel. You see your clinical sensitivity very high, 96% for EGFR mutations, and the high 80s for many of the other mutations. High tissue concordance there on the right side, into the well into the 90%, and of course 100% clinical specificity. If this test finds it, it's there. Treat it. Feel good about it. Next slide, please. There's also the VeriStrat test that you will get for early stage patients. So this is a proteomic immune profiling test, which is something unique to Biodesix and I find very interesting. So let's talk about it a little bit. Next slide, please. So VeriStrat is a test that identifies chronic inflammatory states that are going to be associated with more aggressive malignancies. And they've shown through the INSIGHT studies that it predicts patients that are going to do better or do worse with very good accuracy. VeriStrat good patients have median survivals that are 2 to 2.5 times longer than those with VeriStrat poor, and that's independent of virtually any other clinical factors. Again, you get this back quick. It's a protein-based test looking for chronic inflammatory states that are associated with aggressive cancer. So what am I talking about here? Next slide, please. Here is information from the INSIGHT clinical study where you're taking non-small cell lung cancer patients. On the left side, you've got early and advanced stage patients. And then on the right side, we're showing that same type of patient population, but now you've stratified out according to VeriStrat good and VeriStrat poor results. And what you see there is that early stage patients that are VeriStrat poor actually do much worse than early stage patients that are VeriStrat good. They do almost as badly as more advanced stage patients that were VeriStrat good. So you're able to take these otherwise heterogeneous populations and really draw out two populations according to their VeriStrat status. Next slide, please. This slide just shows that VeriStrat is reliable in being able to detect more aggressive malignancies, not only in early stage patients, but even in stage 1 and stage 2A, as well as your regional patients, stage 2B and 3A. Again, able to draw out two separate populations. So how does something like this make clinical relevance? Well, it can help you identify patients that might benefit from additional treatment or very close disease surveillance. An example of how I might use this is a stage 1B patient, where according to NCCN guidelines, you're in sort of this area where they say, well, you could do chemotherapy if they have high risk factors, but observation is also a valid choice. Well, if I have a patient like that and they've got a VeriStrat poor result, in my clinic, you're likely going to get chemotherapy unless I have some compelling reason not to. And other patients with VeriStrat poor are at least going to go on to very close clinical surveillance. Next slide, please. All right, so same test, except what if you're dealing with a patient that's advanced stage non-small cell lung cancer? Well, you get the same basic test, but the GeneStrat test is now turned into a next generation sequencing test. It's a 52 gene test. Next slide, please. Again, 52 gene panel, you get results in about 72 hours. And what I wanted to highlight here is this is clinically validated to detect single nucleotide variants, insertions, deletions, copy number variants, fusion, skipping variants. So we're not just looking for your common, single nucleotide variants. This is actually clinically validated for most any of the mutations and genetic changes that we're going to be interested in. Next slide, please. These are, this is actually the 52 genes that are part of the panel. You'll see things here that are highlighted in blue or things that are already known to be actionable currently. And then a lot of other things that might be relevant in the near future or in clinical trial, things like PIK3CA is talked about a lot, IDH1 and 2, CCND1 and 2, and 3. So a lot of good information here that not only helps you know how to treat a patient now, but can also help you get a patient on a clinical trial or have that information available should something become actionable in the future. Next slide, please. So what about VeriStrat? You still get a VeriStrat result when we're talking about advanced stage, but the way we use it's going to be a little bit different. Next slide, please. So with VeriStrat, again, you're looking for some of these chronic inflammatory states associated with more aggressive malignancies. And I find this extremely interesting because in this slide, you see we take a patient population on the left, and we select out the PD-L1 high patients. And for this, it was patients that are over 50% PD-L1 positivity. And these are patients being treated with just immune checkpoint inhibitors as a monotherapy, something that has been common to do, something I've done myself as well. And what you see is that you take these patient populations and you've actually been able to identify two different PD-L1 high populations, one that's VeriStrat good and does very well on immune checkpoint inhibitor monotherapy, but then one that's VeriStrat poor and does very poorly on immune checkpoint inhibitor therapy. Median survival there is about 2.6 months. If you've done a lot of lung cancer oncology, you've definitely had immune checkpoint inhibitor patients that seemed like great candidates, but for some reason they just crashed and burned. I never had a great explanation for this until I learned about this testing. And let's go ahead and show the next slide too. So the next slide, again, we're taking a patient population, selecting out the PD-L1 high patients, but these patients are getting immune checkpoint inhibitor plus chemotherapy. And you see by adding chemotherapy on, we're now able to get those VeriStrat poor patients to behave very similarly to the VeriStrat good patients. So you've really taken someone that did not do well in an immune checkpoint inhibitor as a single agent strategy and been able to get comparable outcomes to if you had a VeriStrat good status to begin with. Next slide, please. So this is just some example of IQLung when I've used it in my clinic. You have patient disease status early versus advanced stage. In advanced stage, detecting about 43% of patients having a mutation, which is probably around average. Nationally, you see VeriStrat poor versus good, VeriStrat poor rates in early and advanced stage cancers. Not a ton of VeriStrat poor patients, but they're definitely out there and even in early stages. And then the mutation detection rate at the very bottom. I don't have a very high early stage mutation detection rate, but my clinic is also largely fed by a lung nodule program and a lung cancer screening program. So we have a lot of squamous cells, a lot of smokers where your mutation rate is going to be a little bit lower, but we definitely still find them. And this isn't, I usually back IQ up if it's negative with tissue-based testing, and I'm not finding them there. So it's not that I'm missing them, they're just not a lot of patients with them. Next slide. So here's a case example. I kind of use this to show how the VeriStrat test works. This is a 70-year-old male, performance status about 1, was diagnosed with stage 4 squamous cell carcinoma. EGFR wild type, and he had PD-L1 that was 50 to 60%. He also had a tumor mutational burden that was high. So I sent off IQLung for him, and I got the NGS results back, which didn't show any targetable mutations, but he did have a couple TP53 mutations, TP53 being the prototypical oncogene. So that was interesting. And what else was very interesting is on the next slide, he ended up having VeriStrat poor results on his IQLung testing. So again, this is a gentleman where if I had have been earlier on in my career, seen that he was PD-L1 high, TMB high, performance status not perfect, the temptation there to put him on immune checkpoint inhibitor therapy would have been very high. But from my experience and my understanding of how some of these chronic inflammatory states work and really sort of deactivate the immune system in someone's cancer, I realize now that because of his VeriStrat poor status, I'm going to be putting him on immune checkpoint inhibitor as well as chemotherapy, because this isn't a gentleman that I want to see crash and burn just a few months after starting therapy with advanced disease. And I know that is a very likely outcome for him if I don't push to give chemotherapy, where I can really improve his overall outcomes. And I think that's an important kind of lesson I've learned using IQLung in my clinic. Because some physicians will see a PD-L1 high patient and just put them on immune checkpoint inhibitors plus chemotherapy from the get-go. They've been burned before by monotherapy with immune checkpoint inhibitors, so they just don't do it. I don't love doing that in my clinic. I feel the reason for that is I can now select out those patients that are going to do well. And if I have a patient that can do well with immune checkpoint inhibitor as a single agent, then I'm sort of doing them a disservice by adding chemotherapy onto that. Because not only am I exposing them to toxicity that I don't need to, I'm also blowing through my best second line therapy. Because if that patient advances, has progressive disease on immune checkpoint inhibitor, well then, platinum-based medicine is generally going to be my next best go-to. So that's kind of IQLung. Going through it about as quickly as I can, and especially VeriStrat and how I use it in my clinic. Again, I found it very useful. I'm able to see patients now and get them on treatment a lot of times within a week of seeing them. And that's really become, made me popular with some of the referring physicians and pulmonologists around town. Because the traditional way is a lot of times you see a patient, it's a month or more before they get started on treatment. And we're really doing a better job of getting these patients identified and treated early. And I think that really makes a great outcome in their satisfaction as well as their clinical outcomes. So thank you all for listening.